Well, it just may happen, David. We may have you back when we're face to face. And after watching that, I see it would be a great benefit for us to do so. So hang in there as everything kind of clears. And turns out that study on flights, that maybe that's one of the safer places on an indoor place to be. So
Yeah.
look, excellent presentation. Dr. Becker, I believe, is going to be trying to join us as well. And we're not sure what really happened there. Dr. Becker, are you here with us?
I am.
Oh, nice and clear again. Excellent. So we have a few questions, and I'll have Dr. Becker join us if that's okay. And then we'll be able to kind of bounce it back and forth. I thought the first one was actually a really interesting question. As we know, there's biologics in other areas of medicine, specifically inflammatory diseases and inflammatory processes, the anti-TNF alpha inhibitors and the interleukin-6 inhibitors. I'm curious, and the question comes out, are we able to also use the CGRP inhibitors in individuals who are already on a biologic?
It's a great question, one that was asked a lot even before the release of these antibodies. And the answer to that in clinical practice is yes. There doesn't appear to be any interaction with any other biologic used for inflammatory bowel disease, rheumatoid arthritis, multiple sclerosis. And we've had considerable experience now using these antibodies in patients on other biologics, as has numerous other investigators across the globe, actually, at least where these antibodies are available. And I have yet to hear about a reaction in the patient who's on another biologic that was assumed to be due to some sort of interaction. So I would say the answer to that right now, based on our clinical experience, is yes.
Excellent. I think that's really great news for those patients. And certainly, I think that makes sense why it's such a popular question as well as the crossover between two of them, although quite different pathways.
Exactly.
So the next question coming in, it's actually a fascinating question. Normally I try to moderate these things and I at least have some idea and I can keep up with whoever's speaking. I'm not in that position right now. So I'm going to just kind of do my best. Are there any newer versions of botulism toxins? Some people seem to develop some sort of tolerance. Is this in the medical literature? And if so, what are your thoughts around that?
Well, when I've been injecting botulinum toxins since 1991, perhaps, for various disorders, cervical dystonia and et cetera. And back then, when we were dealing with a different toxin, actually, and by a different toxin I mean a heavily proteinaceous and very highly antigenic substance, we were seeing neutralizing antibodies develop in 25 to 30% of people. 1998, they changed the toxin and made it, so they took out the vast majority of the protein in the molecule. So it's much less antigenic. And in the phase 2 trials of botulinum toxin in the headache world, where we were required to actually assay for binding and neutralizing antibodies, we didn't see any. We didn't see any, I don't think, because A, we were giving a much lower dose than you give for spasticity or dystonia. And B, it's a different toxin than we were given 30 years ago. And so the FDA didn't require us in the preempt trials. I know this because I was at the FDA and I ran those trials. They didn't require us to even assay for antibodies. So, we don't think that, neutralizing antibodies to botulinum toxin, onabotulinum toxin, or Botox is really a problem in clinical practice. Having said that, can I be absolutely certain that the patients who lose a treatment effect over time or develop a tachyphylaxis, could that possibly be due to a very small group who are developing neutralizing antibodies, even at the smaller dosage because we're using a dose of 150 to 200 units. I guess it's possible, but I think that would be, it's rare that we see antibodies with this new toxin at that dose. There are toxins now being developed. In fact, one was just reported in a press release a couple of days ago, a new toxin that appears to have a longer sort of biological half-life, reported to be effective in dystonia. So I think we may see other toxins that will be evaluated from an efficacy standpoint in migraine, and whether they're less antigenic and whether they're we see similar rates of low rates of neutralizing antibodies with those. I'm not sure yet, but I don't think this is a big issue in clinical practice, at least in headache practice.
Perfect. So I think the last question, I'll open it up to both of you, is really about the future of migraine. You mentioned that, by making it more biologic, we're removing the stigma, although as a psychiatrist, I'd argue that's increasing the stigma by saying that. It's a fascinating concept when we look at those who do respond and those that don't respond. What would the future look like if we've got, 30 to 50% of people responding to these CGRPs, meaning 30 to or 50 to 70% are not? What do we see and imagine in headache care? Is it interdisciplinary? Are there other ways of seeing it? And with your experience, and where do you see the future going? We'll start with Dr. Becker, then we'll shift to Dr. Dodick, and then we'll head over to our break.
Well, I'm a great believer that it takes more than a molecule to treat migraine for many patients. That's why I started the CHAM program in Calgary many years ago. We'll talk a bit more about that this afternoon. So the new drugs are great. Migraine obviously has a strong biologic basis, but like many conditions, other factors also determine how many headaches a patient will have or what their headache frequency will be. David?
Well, I couldn't agree more, Werner. You led the charge in Canada and developed, the premier interdisciplinary program. We've done something similar here at Mayo Clinic. So I couldn't agree more that, I think these drugs perform equally well in our patient population because we're not just putting them on a drug. They see an exercise physiologist, they see a nutrition, they see a neuropsychologist, they see a psychiatrist, they see a physical therapist, they may get nerve blocks, they may get other medications. We optimize their acute treatment. We're doing so much. This is it's a disease management model. Yes, we're introducing a new drug or a new biologic, and that's great, but we're doing so much else for these patients. So, I couldn't agree more. It's not just about prescribing. In fact, that's the reason why I think drugs, when we get them in our hands, we actually do better with them in clinical practice than we see in clinical trials because we're not restricted in what we can do for these patients. So I couldn't agree more. And regarding the stigma, Rob, these patients have often been marginalized and ostracized from practices. Clinicians don't like seeing them because they can't measure the pain. And they think that these patients are at best amplifying or exaggerating their illness, and at worst, maybe malingering. So, and oftentimes stress has been the cause of the problem rather than a trigger. We know that stress triggers a whole host of systemic diseases, and we're now working out the neurobiology of how stress could actually trigger migraine. But what I think is that this has actually made what was previously thought to be not a real legitimate biological disease like fibromyalgia into one that is. Not that it in any way minimizes the profound need for biofeedback, cognitive behavioral therapy, and management of comorbid depression, anxiety, and other psychiatric disorders, which commonly occurs in these patients.
Look, I really appreciate it. I was lucky enough to hang out with Werner for a little bit and to know that I was working in the same clinic as Dr. Becker and seeing some of his patients was, as you mentioned earlier, it's an honor to be standing here with him and to be on stage with the two of you, like virtual stage. This is pretty amazing. And really, really appreciate you taking time out of your day, David. And feel free, we have a headache symposium coming up next and another question and answer. We would love to have you there, but that's in no way, trying to pull you into something in a busy day that I'm sure you already have. For everybody else out there, stay tuned. We're going to be throwing this over to Dr. Elizabeth Saxon, the incoming president of the Pain Society of Alberta. And really an honor and a privilege to have two of the world's most foremost headache specialists on stage at the same time. For everybody watching, you don't get much of a better opportunity to see this, including people living with migraines. Here's really your two experts. I hope you got an opportunity to learn a bit about that, and stay tuned for more headache knowledge coming up, including our excellent panel of specialists from some of our local clinics, and really, really appreciate everybody being here.